So now I'm going to invite the second speaker. She is Dr. Celeste Williams. Dr. Williams is the medical director of the Advanced Heart Failure and Cardiac Transplant Program at Henry Ford Hospital. She graduated from the University of Health Sciences Chicago Medical School and did her residency at Loyola University Medical Center, Chicago. She did her fellowship in cardiology at Henry Ford Hospital and went to Cleveland Clinic for Advanced Heart Failure and Cardiac Transplantation Fellowship. She is a member of American Society of Artificial Internal Organs, United Network for Organ Sharing, the Heart Failure Society of America, International Society of Heart and Lung Transplantation, as well as other professional societies. She is affiliated with Wayne State University as an instructor of medical students and residents. She published so many papers, and she is actively involved in the research studies. She is going to talk today about risk factor and epidemiology of congestive heart failure. Dr. Williams.
Thank you. Well, thank you for inviting me. I feel very privileged to talk amongst such esteemed colleagues. Today we will be talking about heart failure and the epidemiology of it. And here are my disclosures. And some of the objectives today. Today I want to review the epidemiology of heart failure. By the end of this lecture, I want you to be able to identify the risk factors for developing heart failure. And lastly, I want you to be able to identify heart failure patients who are at increased risk for mortality. So we all know that heart failure is a major and growing concern in the United States. About 5.8 million Americans are living with heart failure. And if we look at the incidence of heart failure, this is the Framingham Heart Study looking at patients over a 50-year time period. But when you look at the temporal intervals of these patients, basically over a 50-year period, the incidence of heart failure in men is greater than women. The incidence of heart failure in men has stayed the same. However, the incidence of heart failure in women in this cohort of patients decreased about 1/3 by 1990 to 1999. If we look at Medicare population, we really all know that heart failure is mainly a disease of the elderly, but every decade a person increases, every decade their incidence of heart failure increases. So by 90 years or greater than 85 years of age, the incidence of heart failure is relatively high. If we look at the incidence of heart failure as far as race is concerned, if we look at the Health ABC study, that was a study looking at communities in the South. They looked at 3,000 patients. These patients were between the ages of 70 and 79, and they followed these patients over the course of 5 years. And what they found out is the incidence of heart failure is higher in black men and black women. Now, looking at the Cardia study, that was a study looking at a prospective study looking at patients starting at the age of 18 to 30, and they followed these patients for about 20 years. And what they found out is that black men had heart failure earlier, before the ages of 50, and it was associated with certain risks: hypertension, chronic renal insufficiency, and LV dysfunction. So these studies Framingham was a different population, but these studies kind of help us see how race plays a part in this disease. This is Olmsted County looking at over the last 10 years between 2000 and 2010. And basically you can see these are temporal trends for the incidence of heart failure. In this communities, the incidence has kind of decreased between men and women. And this is both heart failure with preserved EF as well as heart failure with reduced EF. So what is our lifetime risk for developing heart failure? Well, if you do not have coronary artery disease, and this is the Framingham population, lifetime risk at the age of 40 is 1 in 9 for men and 1 in 6 for women. And this is if you have no history of MI. But for overall lifetime risk, is 1 in 5 for men and women. So something happens, and this if you exclude coronary artery disease. So something happens with women that even if you exclude coronary artery disease, their lifetime risk is still pretty high. It's 1 in 5. So the prevalence of heart failure, this is looking at a Medicare beneficiary population, has increased over the years in both female and in men. So let's move to heart failure hospitalizations. We all know that's a concern, and the 30-day rehospitalization is pretty high, and that's one of the reasons why the government has chosen that as a measure to look at for reimbursement. So most hospitalizations, readmissions have improved. In 2010, it was around 25%, but most hospitalizations have improved somewhere down to 18 to 19%, but it really depends on where you live. Our hospital is still struggling at around 25, 26% for the 30-day readmission rate. And when you look at the data, heart failure hospitalizations is the main driver of costs. We spend about $40 billion a year in heart failure, but 53% of that cost is spent on hospitalization. So to reduce the hospitalization will help with not only the cost, but it's going to also help with mortality. So when you have a patient who's admitted with heart failure, their 1-year mortality, if they've been admitted just one time, their 1-year mortality is somewhere around 34%. Just one admission for heart failure, all cause. If they have 4 admissions in the year, their 1-year mortality risk can approach somewhere around 56, 57%. So if we could prevent these hospitalizations, not only could we help with the cost, but we can improve the outcomes of our patients. So looking at survival outcomes. So survival with patients in the Framingham study. So remember, this is a 50-year interval. We're looking at patients. And over the 50-year time span, really there has not been a lot of improvement in survival. It's a little bit better in the 90s, but for both men and women, survival is still quite poor. So we're now going to go up to some observational studies that are more recent. The Canadian observational study looked at both heart failure with preserved EF as well as heart failure with reduced EF. 1-year survival is not that great. But if we look at the Mayo Clinical Observational Study, which they looked at patients with heart failure with preserved EF and heart failure with reduced EF, the really point of this slide is the 5-year survival is poor for both types of heart failure. So it doesn't matter, just because a heart failure patient comes in with an EF of 55% and congested, you really shouldn't say yay, because their survival is still very poor. And we all know with heart failure with preserved EF, the treatment is a little bit more challenging. So point, doesn't matter what type of heart failure a patient has, they have a very high risk of mortality. So this is looking at 1-year mortality of patients over about a 10-year span. And once again, it really hasn't changed. From the 90s to 2008, the 1-year mortality is still around 30, 32%. So it has not changed much. When you have a patient with class 4 heart failure symptoms, someone who's short of breath at rest, and we're assuming that they're on the appropriate standard medical therapy and device regimen, when these patients, if they're still short of breath at rest, these patients that have class 4 have mortality rates similar to cancers, like a pancreatic cancer or a lung cancer. So when we see these patients, we need to know their risk of death is high. So what about outcomes associated with race and gender? Once again, looking at the ABC study, they looked at patients. Basically what they found out, the outcomes were similar with the race, but what they found is that Black patients had a 2 times higher incidence of being hospitalized, which is kind of interesting because hospitalizations are associated with death. So higher risk of being hospitalized if you're African American. So we know we use the ACC/AHA guidelines to stage our patients, and staging is very important. It's very important for the clinician because you need to know where your patient is to know how to treat the patient. So If you have risk factors for developing heart failure, the goal of stage A is to treat the risk factors. But what about the patients who have stage B heart failure? They have absolutely no symptoms, but they may have left ventricular hypertrophy, they may have a low EF, but they have absolutely no symptoms. Well, the guidelines are going to tell us to treat them a certain way, but these patients are a little bit special. So when we look at the prevalence of stage B patients, it's around 23. If you look at the age groups, the prevalence is it's high, you know. These patients are asymptomatic, but they may have asymptomatic LV dysfunction. When we look at the mortality of the patients, you can see is higher than the stage A patients. So their hazard ratio is 4. So these patients have a higher chance of dying. Although they're asymptomatic, feel great, these patients are still at risk of dying. So when we look at asymptomatic patients with LV dysfunction, they have approximately half the mortality rate of those with overt symptoms. However, the risk of death is 5 to 8 times higher than a normal age-matched population. And in the SOLVE prevention study, it showed us that patients with untreated asymptomatic LV dysfunction develop overt heart failure symptoms at a 10% annual rate, with a further 8% annual risk of death or hospitalization. So these patients, although they have no symptoms, they're at increased risk of death. So I'm not going to go over I'm just going to go over what you shouldn't do for these patients. So when you have a stage B patient who is asymptomatic, you should not use DIG on the asymptomatic, low EF sinus rhythm patient. There's no data to say that that's going to improve their outcomes at all. So DIG should not be used in this population. Nutritional supplements have not been proven to help these patients. You know, there's no data for that. And we all know that calcium channel blockers that have a negative inotropic effect may be harmful to asymptomatic patients with low EFs and no symptoms of heart failure after MI. So once again, we look at staging. Staging is very important. It helps us know where our patient is and where they may progress to and how we intervene to stop the progression. You got to remember about staging, you cannot move backwards on staging. If a patient becomes a C, you know, they have structural heart disease with symptoms, they always will remain a C, or they can move to a D. But just because you take care of their symptoms and diurese them, they can't move back. So once a C, always a C. So staging is a little bit different than the NYHA classification, which you can move, depends on your volume status. So who's at risk for developing heart failure? Well, we know some of the major clinical risk factors. We know that being older, age is important, being a male, hypertension, having an MI, having CAD, a diabetic. All those are very important risk factors for developing heart failure. So we know there's hundreds of risk factors. And that's when it becomes a little, because you know, a lot of people have been exposed to these different risk factors or different toxins, so it's a little bit difficult, but there's hundreds of risk factors present. So when we look at the Framingham heart study again, remember this is the population from Framingham, Massachusetts. Basically, if the patient if they were male, if they had hypertension, their population attributable risk was pretty high, both in male and females. So that was a huge precursor for developing heart failure. As well as if they had myocardial infarctions in the past, that's a risk factor. So basically, if they have hypertension and CAD, their risk of developing heart failure is quite high. But remember, Framingham Heart Study is a population that is not as diverse. So we're making a lot of generalizations to other populations that are maybe a little bit more diverse. So this is where different studies have come up. This study looked at the epidemiology and incidence of heart failure in elderly patients more recently. And it didn't matter if the participants were African American or white, it didn't matter. They still had, if they had hypertension or CAD, the risk of having heart failure was much higher. So it really related well to the Framingham study. So we can use this data, what we found out earlier on other populations. So if we treat hypertension, the study was looking at patients who are actually older than 80. If we treat hypertension, we can decrease the risk of non-fatal strokes, deaths from any cause, and we can decrease the incidence of heart failure. So just by treating hypertension, we can change the outcome. And I am a heart failure cardiologist. This is what I do. However, as I get more mature in my career, I want a job too, by the way. I want to work. But I think we really need to do a better job on prevention. I mean, there's so many things we could do as clinicians to prevent the disease and prevent poor outcomes. And I think we just need to be more aggressive in treating blood pressure. And I know the patients are resistant. Most of our patients, they forget to take their meds, supposedly, before they come to the office, and their blood pressure's high. No one wants to increase their meds, but I think we really need to be more aggressive at treating it. So we know from different meta-analysis and randomized trials that treating high blood pressure is excellent. You're going to decrease the risk of heart failure, LVH, strokes. I mean, it's pretty much everything. Vascular events, just by treating blood pressure. So many people will go out of business by treating blood pressure, So how does obesity affect, or how does the obesity increase your incidence of heart failure? Well, the heavier a patient is, whether man or female, the more likely they are to develop heart failure. However, there's a little bit of obesity paradox. Studies have shown us that just because the obese patients with heart failure, they don't necessarily have a worse outcome. So although they're more at risk of getting heart failure, their outcomes are not worse than their smaller counterparts. So there's a little bit of a paradox with obesity. We know that diabetes, if we control, better glycemic control will decrease the rate of heart failure. So that's very important. The lower the hemoglobin A1C, the less the risk of the patient developing heart failure. So when we look at the guidelines for heart failure management, when we look at the stage A, the important thing is to treat the risk factors so the patient does not progress. So treating the risk factors is extremely important, the hypertension, the diabetes, the hyperlipidemia, the physical inactivity that's associated with development of heart failure, smoking cessation. All these things are very important in the development of progression of heart failure. So who's at risk for high mortality? Who's gonna die with this disease? Well, when we look at the SOLVE data, we know that the NYHA class is associated with the mortality. So the higher the class, the more likely the patient is going to die. So when the patient is short of breath at rest, that patient has high mortality. Physical exam is very important into determining who is at risk for death. The third heart sound is very important, and an elevated JVP is very important. As Dr. Haywood mentioned, it really is associated with their cardiorenal status. If someone has elevated JVP, we can treat it, but it is a marker of early mortality. Also, we've seen in ambulatory patients with heart failure, they have elevated troponins. And this study looked at 136 patients that had stable heart failure. Their EF was less than 35%. And basically what they found is these patients with the elevated troponin at baseline had a higher risk of death. BNP is also very important, and elevated BNP is important to patients' outcome. Now, we often will use BNP to kind of guide our therapy in the chronic heart failure patients. No data to prove that that's the best thing to do. But of course, the BNP, the patient will serve as their own control, and we use BNP, and it can be helpful. We also look at sodium as a marker for mortality. The lower the sodium, the higher risk of death. And this is the Optimize HF registry. And basically, if the sodium is less than 134, the patient's risk of death is higher. But correcting the sodium doesn't change their outcomes. It decreases their hospitalizations, but it doesn't change their outcome. Ejection fraction is also an important marker. The lower EF, the more likely the patient is to die of heart failure. EF really doesn't tell us how the patient feels, but it lets us know that the risk is high. Also, when we look at LV size, if the left ventricle is large, the larger it is, the more likely the patient is to die. We use metabolic stress tests to look at the peak VO2, the oxygen consumption. In the VHF 1 and 2 trial, basically the lower the peak oxygen consumption, the higher risk of mortality. So that's another marker we can use for our patients. QRS is another thing we use as a marker. When you look at an EKG, patients with heart failure with very wide QRS, they're at increased risk. This is the VEST study that looked at patients over 3,600 EKGs and basically found that the QRS is an independent predictor of mortality. So, summary of risk factors for mortality. Recurrent hospitalizations is a risk factor, and we're assuming that these patients are optimized on standard oral therapy. Patients that have hyponatremia, patients who have elevated BNPs or elevated troponins. Chronic renal insufficiency, as we heard by Dr. Haywood, yes, that is a risk factor for mortality, as well as using high diuretic dosages. Patients with low mean arterial blood pressure, so these are the patients that they have low blood pressures and you have difficulty putting them on the standard heart failure medications because their blood pressure cannot tolerate it. These patients are at high risk. Also looking at their EFs, LV size, low peak VO2, all associated with mortality. So how do we differentiate who's really sick? You know, what do we use? What strategies do we use to differentiate who's the sick heart failure patient? Well, we could use EF. We know EF is associated with mortality, but the EF doesn't really tell you how a patient feels. I have several patients with very low EFs, and they are still working full time. So I know when patients come in, our knee-jerk reaction is to get an echocardiogram. But if this patient has chronic heart failure, and you don't think there's anything else, differently than a month ago, I'm not sure how the EF is really helping. But it's important to talk to the patient and see how the patient feels, and are their activities or less. But a lot of times you have to really talk to the patient because they're not going to just tell you how they feel. They're going to tell you, I feel great, because all heart failure patients usually feel great in the clinic. But you ask them, well, what are you doing? Oh, I sit and watch TV all day. Okay, well, that's a problem. You want to know how active the patient is. Are they short of breath with their activities of daily living? You have to really talk to them to get the information out, because a lot of times they will not tell you unless they're just fully volume overloaded. How they look is important. If your patient becomes cachectic, that's huge. Now, if you have an obese patient, you can still see if they're cachectic because they have muscle wasting. And lastly, you can use the physical exam as mentioned before. Do they have an S3? Do they have an elevated JVP? That could be very, very helpful. We use prognostic models for predicting survival. We use the heart failure survival score. We use the Seattle heart failure model. And there's HF action model that's also used. And these models are really used to give the clinician as well as the family members more of a realistic idea of the outcome of the patient or the mortality. And I think these are very useful. And the heart failure survival score was really used by Dr. Aronson, developed it, but basically it gives patients, it stratifies patients into low, medium, and high risk, and it really tells us the timing of advanced heart failure therapies. When should we be considering these patients for transplant and now VAD? Now, the Seattle heart failure model is used more in chronic, stable heart failure patients. So this is not the model you would use for the patient who comes in with acute decompensated heart failure, crashing and burning. This is the model that you would use in your clinic. And what's so nice about this model is that you change your intervention, or if they're not on a beta blocker, you add it, and you can see what the changes of what your intervention does to their survival, how you improve their survival by adding the beta blocker, by adding the ACE. So it's very helpful to see in real time how your outcomes will change. But the Seattle heart failure model is not useful with advanced heart failure patients who are in need of like transplant or VAD or inotropes. Is not really useful in that population. So really your chronic stable heart failure patients is the key. When we look at our patients who are admitted with acute decompensated heart failure, it's really important to know who's at risk for mortality when they come into the hospital. You know, when they have this is the ADHERE cart. When they have elevated BUNs, low systolic blood pressures, high creatinines, they have a really high chance of mortality, around 20%. So it's really important that you, when your patients come in, that you stratify them and look at them and not just say, oh, this patient's coming back in with heart failure, but see that this patient is at risk of dying during this hospitalization. So how do you know the end is near? When should you be concerned? Well, if every time you diurese the patient, you have a rising creatinine and it doesn't go back to baseline. Creatinine is going to be very important because when you think of advanced therapies, you want the kidneys to work. So that's very important. When the patient starts losing weight and it's not fluid, that's another indicator that the patient's becoming cachectic and mortality is going to increase. When you start needing higher levels of diuretics to diurese the patient, also an indicator. Patients who are intolerant to standard medications. And typically, I don't see a lot of patients that I'm able to max out the dosages because their blood pressures do not tolerate it. But some patients, you maybe be able to max out the medications. But typically, intolerance that I see in my clinic is that patients cannot tolerate the medications because their blood pressures are actually too low. Patients who keep on coming into the hospitalization, and patients also who have increased burden of ventricular arrhythmia. So they keep on getting shocked by their AICD. You know, and a lot of times we want to cath them and cath them and cath them, and they've been cathed, 10 times in 2 years, and it's just worsening heart failure a lot of times. So anytime the burden of ventricular arrhythmias get heavier, got to think that their heart failure is progressing. Or if you need inotropes when they come in to get them out of a bad situation. So you need inotropes to improve their hemodynamics, to improve their perfusion. Every time they're coming in, that's a sign that they're really progressing. So the summary of heart failure epidemiology, it occurs more frequently in men than in women, is primarily a disease of the elderly. The incidence is higher in blacks and occurs at an earlier age with worse outcomes. It has a major economic burden, and 50% of the patients will be dead within 5 years of diagnosis. And we do have prognostic models that are useful in predicting survival and determining timing of advanced heart failure therapies. Yes, thank you very much.
Questions for Dr. Williams?
You painted a fairly bleak view of the prognosis, but I'm a bariatric surgeon, and you mentioned some of the problems, obesity and hypertension, diabetes. I'm seeing over and over patients. So my question is, at what point along this inevitable path is it too late to cure their diabetes, hypertension, and hyperlipidemia? By doing bariatric surgery, can you? Oh. And when should I turn patients down when they come to me with these issues?
Wow, that is a great question. I don't have the data to support, but if someone has a risk factor and you're able to help it out, I don't know what age, I can't tell you an age is when it's too late. I think it depends on how the patient looks, and I can't tell you an age, Yes.
Well, I think we published some data last year from a cardiovascular health study showing that people above 65 years of age, diabetes does not contribute as much to the risk unless they already have predisposing diseases. So in people of elderly, you're seeing more and more elderly, if they're 70 years of age, at least for cardiovascular, either MI, coronary mortality, or heart failure, there was not a significant impact.
You had said that treatment of hypertension in patients 8 years or older was very important. You had said that treatment of hypertension in patients 8 years and older was very important. Recently, the JNC8 decreased the stringency of the
It
blood
did,
pressure control
for older
in
people.
People who are older than the age of 60. Do you think that's a bad move?
No. I think it should be decreased. Heart failure, not heart failure, but hypertension is associated to more than heart failure. It's to strokes, is to, cardiovascular disease. I think being more stringent on the blood pressure is a good idea. And there's...
Well, I think last week the sprint trial
Yeah, the sprint trial, yeah.
presented with a great deal of enthusiasm. It was the only thing that was exciting in American Heart Association. And it actually showed that in the elderly above 75 years of age, when the blood pressure was decreased to somewhere close to 120, it was much more beneficial. And particularly in those who had no prior kidney disease and no prior cardiovascular disease, mortality for the first time in a hypertension trial was significantly decreased, and the curve separated within 2 years, which is never seen in hypertension trials. So I think this is going to deliver the message completely new, that we must treat hypertension at whatever age earlier than we are treating before the patient develops target and organ damage. Or that also included, by the way, lack of LVH. So every indication there was that we are treating hypertension too late, and there is no age limit. And this whole criteria for the JNC8 expert now, by the way, that was not JNC8 guideline, it was an opinion of expert, 5 of whom dissented and wrote an opposing article the month after. So there is a lot of argument there.
Yeah.
A question based on that comment regarding Sprint. There's a question of quality of how we check our blood pressures. I mean, in Sprint, they had them in a quiet environment with their back against the backrest, feet flat on the floor, appropriate size cuff. The way that we typically check blood pressures, first thing when you get in, we're holding up their arm. That cuff is too small. So in terms of quality of blood pressure measurements, can you make any comments about ambulatory pressures, checking at the end of the visit, et cetera, et cetera?
Oh, yes. So, we do not check blood pressure correctly. A lot of times our patients are rushing. We should be really waiting the 5 to 10 minutes, checking the blood pressure. A lot of times I actually check blood pressure at the beginning of the clinic and at the end, while they're relaxed and after I've seen them. That's what I do. But you got to see what works with your patient, but I usually do it 2 times in clinic, and my blood pressure is totally different.
Dr. Williams, the same thing for diabetes, like Dr. Rilvani, you mentioned about hypertension. Earlier the better. Diabetes
Yes.
and heart failure.
Yes.
Similar studies have been done on that or not?
Yeah, so glycemic control is very important. Early, you need to treat it. Yeah, yes.
Would you like to comment on sleep apnea as a risk factor, and how does it affect or impact if you treat it well?
Sleep apnea. It is a risk factor for heart failure, and treating it with continuous positive, it doesn't decrease the risk. Sleep apnea, not treating it, will increase the risk of arrhythmias. It actually increases the risk of heart failure hospitalizations also. So treatment of sleep apnea is very important for heart failure, as far as decreasing the incidence of heart failure and the outcomes of heart failure too.
Thank you very much. Okay.
All right, thank you.